is here. Yes.
Good afternoon, everybody. I'm presenting my study on comparative study of hangback and conventional recession of inferior oblique in V-pattern strabismus. So as we know, V-pattern strabismus is usually associated with inferior oblique overaction, and oblique muscle weakening procedures is the mainstay of management. Recession is the most popular method, and Park's recession is practiced worldwide. Hangback recession is classically described for horizontal muscles and a relatively new procedure for obliques. So our aim is to compare the two methods in terms of reduction in V pattern due to inferior oblique overaction, preoperative and postoperative change in the torsional status, and surgical complications encountered, if any, including the postoperative drift. So it was a prospective interventional study on 50 patients in the age group of 6 to 35 years with significant V phenomena, and patients with inferior oblique overaction less than 10 prism diopters were excluded, and other with neurological instability, nystagmus, and fundal pathology were also excluded. So a detailed history was taken, unaided and best corrected visual acuity was obtained after cycloplegic refraction. Prism bar cover test in all the 9 gazes in vertical and horizontal. Torsion using the fundus photograph and assessment of binocularity was done. So stay sutures were put, inferior temporal incision was given. In group A, the conventional recession was done, inferior oblique was dissected, and the suture was passed 3 mm proximal to the insertion point, and the muscle is cut just distal to the sutures. Park's point is marked, which is 3 mm inferior and 2 mm lateral to the lateral border of lateral rectus, inferior rectus, and the new incision point was insertion was made. This is a video showing the conventional Park's recession. So this was the new point, and the muscle was tight at the Park's point. In the another group, the hangback recession, we make a loop of the sutures at 2 mm and 4 mm from the insertion point. The muscle is being cut in between the two loops. The two ends are hanging on the sutures, and 10 mm is marked on the sutures. And in the end, the two ends are retracted on the sutures 10 mm apart. So post-operative evaluation was done on day 1, 1 week, 1 month, and 3 months. This is a clinical picture showing the infantile esotropia with bilateral overaction, pre-op and post-op pictures. Another picture was IDS with V pattern with bilateral overaction. This is a picture of torsion. Pre-operative, there was a 25.5 degree torsion, and post-operative was 18 degrees. Another picture showing the revision. Observation, the mean age group in group A was 13 years, in group B was 12 years. 50% patients were less than 10 years of age, and mostly were esotropias, more than exotropias. The prevalence of amblyopia was there, 16%, and the mean preoperative deviation in primary gaze was 45 diopters in group A and 47 diopters in group PD in group B. So the mean preoperative V pattern was 24 prism diopter in group A, 23.44 prism diopter in group B. Mean reduction was 20 prism diopters in group A and 18.2 prism diopters in group B. Mean reduction was 17 prism diopters in group A and 16 prism diopters in group B. The graphical representation shows a significant reduction in V pattern preoperatively and postoperative. Our main concern was the postoperative drift in V pattern, which there was a slight postoperative drift in both the groups, but the difference was not statistically significant. So both the groups A and group B achieved good postoperative alignment. There are no patients showing hypertropias. We obtained an overall success rate of 94% in group A and 93.6% in group B. The postoperative alignment at 3 months was not statistically significant. This was the earlier studies done on recession and hangback recession, and both the studies achieved good success result. So my conclusion is, outcomes of both the procedures were comparable in terms of reduction in V pattern. But the hangback recession has some additional advantages because it is a landmark-free surgery. It has minimal manipulation and shorter surgical time. It eliminates the need for intrascleral suturing, thereby reducing the risk of inadvertent scleral perforation. Relatively easier method. It may be preferred in children where the working space is lesser and the scleral rigidity low, also in myopic patients, and offers a theoretical advantage of intraoperative and postoperative adjustment of the inferior oblique muscle. So it may be considered as a method of choice in V pattern strabismus with moderate amount of inferior oblique overaction. However, it needs a larger sample size and relatively longer duration of follow-up to conclude anything. Thank you so much.
Thank you, Dr. Ankita. Just a minute, Dr. Ankita, all these slides were bloodless surgery. I want to know what medication you use that these surgeries are bloodless, or you use cautery, that's why it is bloodless?
So usually the surgery is being done by a very expert surgeon. That's why most of the time it is bloodless. But in few cases we may use cautery, sir.
Thank you.
So with that we conclude the session, and I would like to thank
Almost
Dr.
on
Urmil.
time.
Prior to time, sir, we were given 15 minutes. The hall was handed over to us 15 minutes late. So thank you, and we invite the chairpersons of the next sessions.